All right. I guess we can get started. Well, as other people join in, welcome to our next installment of our Neonatal NIRS Consortium webinars and the first meeting of the new year. We are really excited to continue to have speakers about NIRS for this interest group. Just as a reminder, if you are new to these webinars and you're interested in being on our listserv, please reach out. I'll put that information in the chat. Our Neonatal NIRS Consortium is also has a website that's hosted by Dr. Gabriel Altit on the Neocardio Lab site. So we can also put that information in the chat as well. It's a great resource and a forum to ask questions, and we're looking for people who might have some interesting NIRS cases to post that, to share the information with the group. Okay, and then again, as a reminder, if you have questions today, please put the questions into the chat box and we'll have time at the end to get to that. I am really excited to introduce our speaker, Dr. Matthew Harer, who is a neonatologist at the University of Wisconsin and a member of the Neonatal Kidney Collaborative. And an expert in all things baby kidney. We are so pleased to have him speaking today about renal NIRS monitoring in the NICU. And with that, let me stop sharing. Matt, are you able to share your slide set?
I think you should be able to see it now. Can you see it?
Yes, perfect.
And can you hear me okay?
Yep, looks great. Okay, the stage is all yours. Thanks so much.
All right. Thank you, Valerie, for the introduction, and thank you everybody for coming today. NIRS has become a passion of mine over the last 6 years, and particularly with a renal or kidney focus. So today, going to talk about renal NIRS monitoring in the NICU, current status, and then future directions that we can potentially take this. I have no financial conflicts of interest to report, and just wanted to also specifically point out that I've not received any funding from Medtronic for any research that I present here or any other NIRS manufacturer. So our objectives today are to first just introduce and talk a little bit about premature birth and then the outcomes of acute kidney injury as well as chronic kidney disease during child and adulthood. We'll then move on to talk a little bit more specifically about oxygen in the kidney, and then move on to really focus on how we monitor kidney oxygenation, what renal NIRS values are normal in the NICU, and then take a look at certain situations where we can expect changes in kidney oxygenation, and then look down the road to what we can hopefully do in the future. So first, I'm going to talk a little bit about kidney development or underdevelopment in the case of premature babies. This was actually a tomato that I was cutting up this summer and now has turned into my research group image and my most infamous tweet. Some people pointed out how this tomato has a kidney stone, doesn't have very many glomeruli, which are the seeds, maybe has a little fibrosis over here on the left side. So just start off with a little fruit or vegetable humor. So going back to in utero development of the kidney. So typically a baby begins to develop nephrons between 10 to 15 weeks and will develop nephrons all the way up to somewhere between 35 and 40 weeks, which is considered full term. And a full complement of nephrons is somewhere above 700,000. However, when you're born prematurely, and particularly less than 25 weeks, if you look at where nephron development is around that time, it's only around 200,000. There's a few nice studies that show that you probably do continue to develop some nephrons for between 4 to 6 weeks after premature birth. But even then, if you develop it just for 4 to 6 weeks, you maybe end up with around half of the normal endowment of nephrons as a premature infant. And we also know that the nephrons you develop after birth are not normally developed and they have some histologic differences. So premature birth leads to what we've called oligonephropathy, or a reduced nephron number. Ultimately, what that does in the future is it leads to hyperfiltration of the kidney, which then leads to systemic hypertension, can lead to proteinuria, and then ultimately ending in nephron loss and glomerular sclerosis, which leads to chronic kidney disease. There's been a couple of really nice studies over the recent years, particularly by Casey Crump, that has shown the risk of developing chronic kidney disease as an adult between the ages of 30 and 50 years. And here in this figure, you can see for all preterm infants born less than 37 weeks, the hazard ratio for developing chronic kidney disease is 1.94, or nearly 2 times the baseline value. And just a reminder to everybody to please mute if you've just joined. And then if you look at extremely preterm birth, less than 28 weeks, those babies actually have a 3-time risk of developing chronic kidney disease by the age of 50 years. So definitely premature birth leads to a higher risk of chronic kidney disease, and probably due to the underdevelopment or oligonephropathy. I like to think about the risk of chronic kidney disease as being a 2-hit model. So you can have an adverse intrauterine development that leads to abnormal kidney development. You can have adverse neonatal environment. So we know babies who are in the NICU are exposed to hyperoxia, nephrotoxins, sepsis, inflammation, and hypotension. They can also develop acute kidney injury due to nephrotoxins, sepsis, IVH, HIE, all kinds of different things in the NICU. And then there's also childhood factors that can contribute to the progression of CKD, like obesity, malnutrition, high salt diet, and hypertension. So really, ultimately, the goal of my research is to try and figure out ways that we can protect the kidney while babies are in the NICU, knowing that they already have an underlying baseline risk of underdevelopment that leads to chronic kidney disease. And one way that I think we can potentially do that is through NIRS monitoring. So I want to just spend a couple minutes here talking about acute kidney injury in the NICU. So the AWAKEN study that was done nearly 10 years ago now really showed us the incidence of kidney injury in premature babies. So if you take a look at the the upper right-hand corner here, in babies 22 to 29 weeks, nearly half of those babies experience acute kidney injury at some point during their NICU stay. If you look at the 29 to 36 week babies down here in the lower right-hand corner, only about 1 in 5 babies experience acute kidney injury, so relatively healthier population. And then if you look at the term babies, there's generally a very good reason why those are admitted to the NICU, as they're more sick. Those babies have about a 1 in 3 chance of having acute kidney injury when they come to the NICU. So acute kidney injury is very common. And what the AWAKEN study showed is that there's an independent association with mortality, as well as a longer length of hospital stay. So acute kidney injury is really very important in the NICU, and we know that it can also accelerate the course to chronic kidney disease. One potential final endpoint or mechanism for acute kidney injury is hypoxia. So the most common causes of acute kidney injury in neonates being nephrotoxins, hemodynamically significant PDAs, hypotension, anemia, all ultimately lead to decreased oxygen delivery to the kidney, and ultimately can result in acute kidney injury. So utilizing NIRS monitoring to measure oxygen values in the kidney could be one important step to the earlier diagnosis of acute kidney injury in these babies. So before we get into the NIRS monitoring, let's talk a little bit more about oxygen and the kidney. So first, the kidney is one of the most metabolically active organs in the body. So it uses approximately 7% of the daily energy, which is the same as the heart, and more than the liver, the brain, or any other organ, really. Over 80% of the oxygen that's consumed by the kidney supports active transport, and this is primarily the sodium potassium ATPase. So when you use a lot of energy, you need a lot of oxygen. And oxygen delivery in the kidney is really very differential. So I really like this image because it points out the different partial pressure of oxygen by the different color gradients throughout the nephron and out the kidney. So we know that the partial pressure of oxygen in the kidney has enormous variation. The highest amount of oxygens are in the highest amount of oxygen is in the cortex where there's the highest blood flow, but we know that the oxygen tension gradient grows as you go deeper into the kidney and along the proximal tubule. And particularly the S3 segment of the proximal tubule is at particular risk for hypoxic damage due to its underlying very low hypoxic environment that it already lives in here, less than 40. So how is oxygenation of the kidney actually determined? And we're going to work backwards here. So you have your renal tissue PO2, which is in part determined by your oxygen delivery, which is determined by your renal blood flow, and then your arterial oxygen content. And then, so that's how much oxygen is going to the kidney, but part of it depends on how much oxygen is being consumed by the kidney, which is driven by tubular sodium reabsorption and your glomerular filtration rate, which is determined by your renal perfusion pressure and your pre to post glomerular resistance ratio. So the kidney is very complex. And when we think about oxygenation, we both have to think about how much oxygen is going to the kidney and how much oxygen is being used by the kidney. So there's a couple different ways that we can assess oxygenation in the kidney. One potential way to do it is through MRI, and these techniques are still being developed, but you can see in this image how differential the oxygen delivery to the kidney is here. You can also do blood flow studies with ultrasound. You can actually look at urinary oxygen tension, and then the way that we most commonly measure kidney oxygen values in the NICU is through NIRS monitoring. So for those of you who aren't familiar with NIRS, NIRS measures regional tissue oxygenation continuously from a light source to a light detector along the sensor. So the non-invasive sensor emits near-infrared light from the source to the detector at 700 to 850, and the partial absorption of light by oxygenated and deoxygenated hemoglobin in the tissue microvasculature below. The actual formula is oxyhemoglobin divided by oxyhemoglobin plus deoxyhemoglobin times 100, and then the machine displays a percentage. It's very similar to pulse oximetry, where pulse oximetry is a global estimate of your pre-capillary oxygen delivery to peripheral tissues, but the data comes from pulsatile or arterial sources. NIRS measures regional oxygenation, so it expresses the full tissue hemoglobin oxygenation without subtraction of the non-pulsatile data. We believe that individual tissue segments are a mix of 20% arterial, 75% venous, and 5% capillary. And thus, NIRS provides predominantly a post-capillary tissue oxygenation, or a surrogate estimate of what your local tissue oxygen utilization is. So this is really important, the critical oxygen point theory. So as oxygen delivery decreases, oxygen extraction goes up to maintain tissue homeostasis. At some point, a critical oxygen point is crossed, beyond which ongoing tissue oxygen utilization becomes oxygen delivery dependent. And below the critical O2 point, dramatic increases in tissue extraction are needed to meet the tissue needs. And this is often then accompanied by clinical signs of oxygen consumption mismatch. And this is where NIRS becomes important, because hopefully NIRS can detect it when these dramatic increases in tissue oxygen extraction are needed. So when looking at it from a kidney standpoint, along this timeline here, where going from normal to damage to decreased GFR, ultimately kidney failure and death, we're trying to determine a window for early intervention here, either before damage occurs or at least when the damage is still reversible. Currently, unfortunately, our diagnosis of acute kidney injury is done by changes in urine output and changes in serum creatinine, which are relatively late findings, particularly in preterm infants, when the GFR is already decreased due to the damage. So we're hoping that with kidney oxygenation monitoring and NIRS monitoring, we can develop this window for early targeted intervention and also assessing the risk for acute kidney injury. Kind of like I talked about before, I like to think about renal tissue oxygenation as an issue of supply and demand. So when thinking about oxygen delivery in the setting of a preterm baby to the kidney, you have to think about cardiac output and low cardiac output states. You have to think about hemodynamically significant PDA, causing reduced blood flow. You need to think about your hemoglobin levels, if there's been acute blood loss, or if anemia could be playing a role in your reduced oxygenation. And then you'll also have to think about renal blood flow and the potential for thrombosis. When thinking about demand, there's a lot of different situations where either the renal oxygen extraction is going to go up or down, and you have to try and figure out why and which way the kidney is working. So in general, a couple situations here that I'd like to point out. So when you actually have normal blood flow, but decreased demand, you may see that your renal tissue oxygenation is higher than what you would normally expect it to be. However, if you have a reduced supply but normal oxygen extraction, then you're going to see a renal tissue oxygenation that is lower than what you would normally expect. So every time I think about a renal NIRS value, I try and think about both the supply and demand. So now let's get into the nuts and bolts of how we actually do kidney oxygenation monitoring in the NICU. So the positioning of the probe is extremely important. So you want to place the NIRS sensor on the posterior flank, and you want to find the place below the last rib, but above the iliac crest. And when you palpate this area on preterm babies or term neonates, it really is about the size of the neonatal sensor, or just about the size of the width of your pinky. So really there's one spot that the sensor should go. You should make sure that the tip of the sensor and the light emitting diode does not overlie the spine. So you want to be about 1 centimeter away from the spine. And then depending on the size of the baby, the rest of the NIRS electrode may actually wrap around the flank. Here's just an example of the NIRS sensor on a mannequin here. And this is shown with a piece of Mepitel, which we use in our unit to protect the skin of the preterm babies. I've seen, now that I've been doing NIRS research for a while, nurses have a tendency to do a lot of different things with these sensors. So I've seen numerous times where they'll actually place the sensor midline over the back. And then we have to do some re-education to try and point out that we want it just being measured on one side, because I'm not exactly sure that we get a real reading when it's placed centrally across the back. And I've also seen it where the probe has been rotated, so the light emitting diode actually ends up on the anterior part of the abdomen and the reading part of the sensor is on the back. And then in that situation, you're probably more getting intestinal oxygenation. So when teaching nursing staff, we have to be really specific about where we want the probe. And if you're not getting the reading that you would expect to see, really investigating how that sensor is placed. Like I mentioned, the Mepitel, typically we only use for skin protection in the premature infants or the infants who have unique skin issues. We place the sensor on top of the Mepitel. We've developed protocols where we move the sensor every 6 hours with cares to the opposite side of the body, just to try and give that one side of the body a break, since oftentimes the babies are laying supine and we don't want to develop any pressure injuries. By moving it every 6 hours, it also allows us to easily monitor for erythema and bruising on each side. There's several ongoing questions as I've done this more and more that I'm looking at answering right now in some research. So the first thing that I'm curious about is the depth of monitoring, particularly in the preterm neonates. Typically, the light is going to be emitted 2 to 3 centimeters deep through the tissue. And particularly in the really micro premature babies, I wonder about the actual depth of the kidney. And if the light is going all the way through the kidney and potentially also into the intestines. So you're actually getting a combination of intestinal and kidney oxygenation. So that's one question that I'm trying to answer with a study where we're actually using the ultrasound probe to measure the depth of the kidney and try to get more answers or figure out what sized babies we're probably just getting kidney oxygenation on versus a combination of kidney and intestinal oxygenation. I also wonder if the side of monitoring matters, particularly in the first week of life when the babies may have persistent meconium. So wonder on the left side with the colon, and if there's persistent meconium that may interfere with the light, and there's been a couple publications as it relates to that. I also still wonder about some or some phototherapy interference or even direct hyperbilirubinemia that can interfere with the tissue oxygenation reading. So that's something that is an ongoing question in my mind that we need to answer. And something to think about if you're monitoring your renal NIRS, but perhaps the baby's prone and the bilirubin light is interfering with your NIRS light. So now I'd like to move on from how we monitor kidney oxygenation to what normal renal NIRS values are in the NICU. So in my mind, there's several things that we need to know. The first thing is really what are normal values by different birth gestational ages. And then we also need to know how renal oxygenation changes as a baby gets older or as their PMA increases. Because one thing for sure is that a 25-week baby in the first week of life probably has a different kidney oxygenation value than that same baby who's then 4 weeks old or 29 weeks PMA. So I think we still are looking for all of that data. I think we need to know what the normal percent variation is hour to hour and day by day in kidney oxygenation, and we'll look a little bit at that. We need to know what are normal values by the type of sensor and type of monitor. And then also, do these values actually correlate to blood oxygenation values or specifically kidney oxygenation values from the blood if we can get them? So there's not a lot of data on what normal renal oxygen saturations are. In a review that Dr. Chalk and I published, we looked at combining some of the data, and there's only a couple of studies for each of these graphs. So the first one here in term babies looks like initially in the delivery room, as you would expect, the kidney oxygenation improves over the first 15 minutes of life to above 80%. And then during the next 12 to 48 hours, the kidney oxygenation stays pretty stable, maybe slightly declines. We certainly could use more data on just term neonates who are healthy to determine what the normal trajectory of kidney oxygenation is in that first 72 hours after birth. And then when we look at preterm infants, we have a little bit longer data. So here this graph goes out to 21 days, and you can see, again, initially an increase in kidney oxygenation that plateaus and then probably starts to decrease at some point in the first week of life towards the first 3 weeks of life. In some unpublished data that we're working on publishing right now, we looked at 2 different centers and found that although the 2 different centers had different absolute kidney oxygenation values, the trend of the kidney oxygenation in the first 7 days was very similar and actually the same when you looked at it statistically, where you see a steady decline in the first 72 hours and then a plateau of your kidney oxygenation. Here, looking at about between 50 and 70 for what a normal kidney oxygenation would be. And this is in preterm babies who are less than 32 weeks. And here, this graph just shows you the percent change from the preceding 12 hours. And you can see there's about a 5% decrease in your kidney oxygenation in each of the first 5 12-hour stretches, at which time it normalizes around 72 hours of age. So again, looking to try and determine what are normal kidney oxygenation values, and we certainly need more data to prove this at other centers. In a study by Dr. Mincer, he looked at normal variation in preterm neonates. So of 24 preterm neonates who had an average gestational age of 27 weeks, looking at their COVAR. Here you can see in the renal is the lighter shaded region here, that it had less variability than the cerebral data. More variability than the cerebral data, but less variability than the intestinal oxygenation. So we could use even more information on how variable the renal oxygenation is. We also need to know how different machines differ in their reading of oxygenation. And this study was done for the Safe Boost study to look at different hypoxic thresholds in a liquid phantom that mimics properties of neonatal heads. And although this is great and can be used to correct for cerebral oxygenation values between different machines, I just want to point out that this has never been done for the kidney. So we really don't know how different machines result in different readings for kidney oxygenation at this point. So whenever you're interpreting a study, make sure to look at if the device that they used in the study is similar to the device that you're using at your institution. One really neat study that I found in the adult literature was they looked at 13 adult patients who were undergoing open cardiac surgery with cardiopulmonary bypass. They found all patients had actually received a renal vein catheter for invasive measurement of their renal venous O2, and then also did external NIRS monitoring for assessment of renal RSO2. And they used ultrasound guidance to make sure that that probe was placed correctly. What they found in each of these colored lines is a separate patient was that there was a strong correlation between the renal NIRS value and the invasive renal vein oxygenation measurement with only a small bias and acceptable agreement. So really showing that at least in adults that the renal NIRS value is an accurate depiction of the remaining venous oxygenation coming from the kidney. I wanted to try and replicate that study, but obviously there's no way that we're going to be able to get a catheter into a neonatal renal vein. But I wondered if when we have our umbilical vein catheters that are sitting in the IVC RA junction here, that's relatively near to where the renal vein comes back. And if that would be a good estimate of what the renal vein oxygenation is. So I looked at comparing some venous blood gases that we obtained from UVCs, and that's up here in figure B, and actually found that there was not a statistically significant correlation between the oxygen values from the UVC to our renal NIRS readings. However, when we looked at the correlation to blood gases from the UAC or capillary blood gases, we found significant correlations in the oxygenation compared to the renal oxygenation from the NIRS values. So something that we need to look at more in the future. And as you can see from these graphs, we had the least amount of data from the UVCs as we obtained most of our blood gases from a UAC or from a capillary specimen. So still more work to do on this to try and make sure that truly in preterm babies that the renal NIRS oxygenation is a true estimate of the remaining venous oxygenation coming from the kidney. So now I'd like to move on to situations when we have alterations or changes in what normal kidney oxygenation is. So the first topic is going to be preterm acute kidney injury and renal oxygen saturation. So Dr. Bonsanti published a few years ago now how low renal oxygen saturation with NIRS on the first day of life is actually associated with developing acute kidney injury in very preterm infants. And here's the NIRS values that they obtained in the first day of life. And the red values are the babies who went on to develop acute kidney injury in that first week of life. And then the green babies are the ones who did not go on to develop acute kidney injury. So clearly here showing significant differences in the kidney oxygenation as early as that first 24 hours that then went on to predict who was going to develop acute kidney injury in that first week of life. So I think that's a really interesting study and really interesting that you can predict already in the first day of life who's going to go on to develop kidney injury just based on your kidney oxygen values. In a study that my group has published, we looked at 35 neonates who were born less than 32 weeks, only 3 of which had acute kidney injury, all defined by serum creatinine. What we found, and each of these lines is an individual patient. This dotted line is the time of the serum creatinine diagnosis of AKI, and then to the left, the preceding time. And we found that the renal tissue oxygenation was well below 40 in all 3 patients. Over 48 hours prior to the clinical diagnosis of acute kidney injury. When we then compared our babies who had acute kidney injury to those who did not have acute kidney injury, You can see these graphs show the median values with the dark line, and then the shaded region around the dark line is the interquartile range. And comparing the no acute kidney injury had a median of 60% compared to those with acute kidney injury, a median oxygenation of 32%. So it certainly looks like there's something different going on in the babies who are developing acute kidney injury compared to those who are not going on to develop acute kidney injury. From the same cohort of patients, we wanted to look at how caffeine affects kidney oxygenation, because a few studies that we've done previously have shown that caffeine given early can be preventative of developing acute kidney injury in preterm babies. So what we did was we looked at the time the caffeine dose was administered, and then we looked at the first 6 hours after and looked at an hourly average to see how kidney oxygenation changes after caffeine. And we divided this by subgroups. So babies who were less than 40% had the most significant increases in their kidney oxygenation, even up to as high as 15 points in the first 2 hours. But even that lasted up to 6 hours, and in this one group even lasted 12 hours. So this potentially showing that caffeine might be able to be used as an intervention for some babies who have a persistently low kidney oxygenation. However, the babies who were greater than 60% down here actually had a slight decrease in their kidney oxygenation after receiving caffeine. So those babies probably are not going to benefit from a kidney standpoint of receiving caffeine. So moving on to acute kidney injury in babies with HIE, so another really high risk population for acute kidney injury in neonates, where nearly 50% of these babies develop acute kidney injury. So Dr. Chalk's group looked at 38 neonates, 15 of which had acute kidney injury. And what they found was really interesting. And they found that actually renal oxygenation was higher in babies with acute kidney injury compared to those without at 24 hours of age. And if you did some calculations, that if your value at 24 hours was greater than 75% by 24 to 48 hours, it predicted acute kidney injury with a sensitivity of 79%. And a specificity of 82% with an ROC curve of 0.76. So I really like to point this out because it really seems like acute kidney injury is going to be different depending on the patient population that you look at. So in preterm babies, the renal oxygenation may actually be lower in acute kidney injury, but in this group of babies, term babies with HIE undergoing therapeutic hypothermia, the renal oxygenation is actually higher in the group that has acute kidney injury. And it probably points to the fact that these babies experience a different type of acute kidney injury, potentially acute tubular necrosis, where the kidney then is not actually extracting as much oxygen, versus the preterm babies who have lower renal oxygenation might be more due to preload and anemia and PDAs instead of actually true acute tubular necrosis. So speaking of PDAs, there's been renewed interest in a recent publication just this past year that looked at if we can use NIRS measurements to differentiate a hemodynamically significant PDA. So this group had pretty good numbers where 64 did not have a PDA, 41 had a PDA, and then 18 had a hemodynamically significant PDA. And since this is a renal NIRS talk, I'm just going to focus on the renal row here. You can see that those without the PDA had a mean oxygenation of 76 compared to 71 for those with a PDA, and then actually those with a hemodynamically significant PDA of 67, which is similar to data that Dr. Chalk has shown out at Stanford as well. There's also been a couple of studies that have looked at how kidney oxygenation responds to treatment for a hemodynamically significant PDA. So here is an example where a baby who has a renal or who has a hemodynamically significant PDA and looks like pretty similar value to the 67 that was shown in this other study. And when they started the ibuprofen, you can actually see that as the duct starts to close or restrict, your kidney oxygenation actually improved significantly. So I think we need more studies to look at both hemodynamically significant PDAs and then how kidney oxygenation changes in response to Tylenol, ibuprofen, and indomethacin treatment. One area that I think we also need to look at is how anemia affects kidney oxygenation. So red blood cells obviously carry oxygen. So one would expect that renal oxygenation is going to be affected significantly by anemia. However, there's several different studies out there that has shown some variable data when it comes to anemia. So there's been a range of increases noted from 2 to 22% in kidney oxygenation after a transfusion. Would typically have a corresponding decrease in your fractional tissue oxygen extraction. Carrie Borowski, who worked with me this summer, looked at our data set and found that there was a very strong statistically significant correlation with the renal oxygenation values and hemoglobin values in our study. However, when we broke down our data and looked at which babies had acute kidney injury here in the green compared to the babies in the purple who did not have acute kidney injury, we actually found that in the babies with acute kidney injury, that correlation disappeared completely. So something different is going on in the babies with acute kidney injury. And then when we looked at how the kidney oxygenation changed pre-transfusion to post-transfusion in both the AKI group in green and then the no AKI group in purple, we found increases in your kidney oxygenation values. So from the high 30s to the low 50s in the AKI group, and then from about the 40% range to the 50% range in the no AKI group. So increases, although not statistically significant, and not much different between the two groups. So it certainly looks like higher hemoglobin values in transfusions likely increase kidney oxygenation. Another group of patients that we commonly take care of, at least preoperatively in the NICU, are those with congenital heart disease. So congenital heart disease patients in some studies have shown to have a renal oxygenation of around 65 plus or minus 11% compared to control term babies who sit closer to 85%. So very significantly different there. And actually that the renal fractional tissue oxygen extraction is much higher in patients with congenital heart disease, 31 versus 14% in that same study. It's also NIRS monitoring is used commonly postoperatively and is being studied to detect cardiac surgery associated AKI, which is severe and common in this population, occurring in nearly 50% of neonatal congenital heart disease surgeries. And studies have demonstrated that decreasing renal saturation levels during cardiac surgery and in the postoperative period are associated with AKI mortality, the need for renal replacement therapy, and prolonged ICU stay. So certainly this is an area that renal NIRS monitoring is used frequently. A fellow doing some research with me is looking at our data where we have 35 cardiopulmonary bypass cases in neonates less than 28 days. We have an AKI rate of 60% in the cases in the first 72 hours postoperatively. We looked specifically at the intraoperative renal NIRS monitoring and found that the patients who go on to develop stage 2 or 3 AKI actually have significantly lower renal RSO2 compared to the babies who have stage 0 or stage 1 injury after the cardiac surgery. And this is specifically looking at the renal oxygenation after the last bypass cycle, which would be a nice way to, as the babies come up to the PICU or the cardiac ICU after cardiac surgery, to use to predict and guide management of kidney therapies or blood pressure support. Certainly with ECMO, these babies have multiple risk factors for acute kidney injury. So they have major shifts in regional blood flow, as well as deal with a lot of inflammation related to the bypass. So one specific group of patients that has been looked at are congenital diaphragmatic hernia patients on ECMO, where they found decreasing renal NIRS values were associated with lower urine output and also preceded changes in blood pressure, and that a renal saturation of greater than 76% had an AUC of 0.96 for predicting adequate urine output of greater than 1 ml per kilo per hour. So I think as we've gone through this talk, we see a lot of different renal oxygenation values that seem to float around kind of the 65 to 75% as kind of maybe the critical window here of when we need to think about values being abnormal. I think another really interesting place to increase the utilization of NIRS monitoring is actually during surgery. One major potential uses for neonates who are undergoing abdominal surgery, where the intra-abdominal pressure may actually reduce the renal blood flow. So in babies who are undergoing a CDH repair, gastroschisis, omphalocele repairs, or just simple intestinal atresia repairs. There's been a couple of studies that have looked at the evaluation and treatment of intraoperative hypotension. So one study looked at a response to Ringer's acetate boluses and found significant increases in renal oxygenation after those boluses. And then another study looked at when they gave epidural boluses of bupivacaine, they actually found significant decreases in renal oxygenation. So I think we need to collaborate with our anesthesiology and surgery colleagues to try and increase the use of renal NIRS monitoring to try and prevent intraoperative or postoperative acute kidney injury. So finally, to leave a little bit of time for questions, I want to just talk about a couple of future research directions. And please start entering any questions you may have in the chat. So one big question that I have in my mind is, do urine biomarkers change as renal tissue oxygenation changes? So there's been some nice studies that have looked at urinary NGAL and its correlation to serum creatinine, and where they've actually found that if you're urinary NGAL negative and serum creatinine negative, that you have no loss of function or tubular damage. And when you urinary NGAL negative, but you have positive serum creatinine changes, that's probably loss of kidney function without tubular damage. And then if you have urinary NGAL changes without serum creatinine changes, you actually have tubular damage without the loss of function. And then if you have both, you have tubular damage with the loss of function. So this really gets to phenotyping the type of AKI that you have. And hopefully urinary NGAL is going to become more widely used and approved at the FDA level, so more labs can utilize it, because I think that will help us understand acute kidney injury a lot better. But really, I think we need to look at things like metabolomics as well as proteomics to correlate changes in kidney oxygenation in neonates to these markers. So in the future, I think that we could develop something similar where we actually look at NIRS values and how the NIRS values correlate with changes in urinary NGAL to determine if a baby is pre-renal and has tubular damage or does not. And then potentially, let's say you have a higher than a expected NIRS value without urinary NGAL change. Maybe that's a situation that you actually have nephrotoxic injury or a post-renal injury. Or if you have both urinary NGAL changes and NIRS changes that are above normal, potentially that's when you have acute tubular necrosis. So I think we can do a lot more work on determining what specific oxygen signatures are for different type of AKI. An interesting topic that one of my mentors, Dr. Charlton, brought up, who does a lot of work on imaging nephrons, is, do we know what the optimal kidney oxygenation is for continued nephron development? And I think this is an area that's really important, because if we can find the optimal oxygen environment for nephrons to continue to develop, potentially these babies will end up with more functional nephrons and less chronic kidney disease in the future. So as more imaging techniques are developed to count nephrons, we can also do kidney oxygenation monitoring on these babies to really determine what is the optimal oxygen environment for the continued development of nephrons in the future. Potentially not more oxygen is better. And then I think we need to evaluate other common NICU things. So we need to figure out what is the effect of maternal disease, particularly preeclampsia, diabetes, and fetal growth restriction on kidney oxygenation in neonates. I think it would be really interesting to look at how the timing of feeds and whether it's a bolus or a prolonged feed affects kidney oxygenation, because potentially more blood is shunted to the intestines and away from the kidney during those times. I think we need to look at the type of ventilator support and your mean arterial pressure or mean airway pressure and whether that affects blood flow to the kidney. Similarly, mean arterial pressure and your blood pressure and how that affects kidney oxygenation. And then need to do a further analysis of how nephrotoxic and nephroprotective medications affect kidney oxygenation. And then ultimately the goal really would be to develop something similar to what's being used in the Safe Boost trial, where you do continuous monitoring. And if you have an abnormal value that's outside of the expected range, you can evaluate for cerebral NIRS, evaluate for hypocarbia, and then moving on to develop or evaluate for hypoxia, hypotension, and anemia. So in my mind, I just put down a little sketch here of what we could develop for kidney oxygenation monitoring, where you check blood pressure and your urine output, and then consider drawing creatinine, urinary NGAL, hemoglobin, and hematocrit. If you have an increase in creatinine and a positive urinary NGAL, you likely have acute kidney injury. In that situation, you'd want to make sure you're not giving nephrotoxic medication and consider different things like fluid bolus, and maybe in the future, things like caffeine. If you're anemic, maybe the decrease in oxygenation is due to anemia, and you may want to address this per your transfusion protocol. And then if your blood pressure is low, you obviously want to check a blood gas, consider sepsis, and think about pressors. Also checking an echocardiogram to make sure you don't have a hemodynamically significant PDA that needs treatment, and also seeing how your kidney oxygenation compares to your cerebral oxygenation. So at this point, I'd like to just thank my family, so my wife and my kids there, all the great mentorship I've had in the past. So Dr. Charlton at UVA, Dr. McAdams here at UW, Dr. Chalk out at Stanford, and Dr. Capitini here at UW. All of my different mentees who have helped me with this NIRS work, both with the recruitment and data abstraction from the EMR, and then all the different funding sources that have helped with this, the Department of Peds here at UW, the Wisconsin Partnership Program, the NIH and our UW ICTR KL2 Award, the Unite Grant, and the Meritor Foundation. And I would love to take some questions at this point.
Thank you so much, Dr. Harer. That was such a clear and informative presentation. I'm really excited about some of your ongoing work in this field. Please do enter your questions in the chat. I do see a few here. I'm just going to start us off with just a comment. I think some of us in this group had started off in the field of neuromonitoring and really focused on cerebral NIRS. So I think it's so important to emphasize the importance of also looking at other somatic tissue beds. So we at Stanford, and I know you at Wisconsin as well, always do 2-site monitoring with both cerebral and renal sensors, because we know how exquisitely sensitive the kidney is to cardiac output, how it's not as well auto-regulated, and how you're going to see those hemodynamic changes there first. So I'd be curious how others have also utilized renal NIRS. We've certainly seen it in babies that have had hemorrhages or shock as the very first thing that changes. And I know, Matt, you talked about other circumstances where where renal NIRS has really come in handy. You've alluded to, like, for example, we've also talked about babies with critical coarct, and when the duct closes, and maybe that renal NIRS is the first thing that changes. So I'm very curious what others have experienced in both their clinical and research practices in that regard as well. And I should mention, I have my co-moderators, Zach Vasilis and Jonathan Mincer on the line, and they can help me to moderate the chat.
It looks like I have the chat open as well, and looks like Needy had a question about, in the study with caffeine and impacts on NIRS values in premature kids, would you potentially recommend dividing daily caffeine dosing into more frequent dosing, Q6 versus Q12 hours versus Q24 hours? And then also what the proposed mechanism of action behind the impact of caffeine on renal perfusion is. So really great question. I have thought about whether dividing caffeine makes sense. It doesn't seem like it should, because the half-life is so long in premature kids. So I haven't explored that yet, but potentially in the future, that might be something interesting to study. The proposed mechanism of action is that caffeine affects adenosine receptors, which affect renal perfusion. So when you block those adenosine receptors, when adenosine is elevated, you often see acute kidney injury. So if you can block those adenosine receptors, you actually can get improved renal perfusion. So this has also been shown in other methylxanthines like aminophylline and theophylline in babies with HIE. So it's actually recommended by the KDIGO group that in babies with HIE that you give a single dose of theophylline which then can increase your renal perfusion and prevent AKI in babies with HIE. I think that's definitely another area that needs more study, because a lot of that work was done in babies who are not undergoing therapeutic hypothermia. And I know that's an area that Valerie and her group out at Stanford is looking at as well. So I think the methylxanthine story, both caffeine, aminophylline, and theophylline, is still evolving. And I think adding renal oxygenation monitoring to all of those studies is going to be really important in the future. And then looks like Andrew, so does the presence of bilateral cacket, congenital anomalies of the kidney or urinary tract limit renal NIRS utility? I think that's a great question. So far, I've only had a couple of babies that have had cacket, and mostly in the form of hydronephrosis, and it doesn't seem like that changes the tissue oxygenation monitoring, but I would need a lot more babies, I think, to kind of show whether there's a difference in normal kidneys compared to babies who have cacket. So I think that's another great question that we should explore in the future.
And Matt, I would add to that, there's a growing population of well, babies on dialysis, for example, or even those that might have bilateral renal agenesis and trying amnio infusions. And so I think there's really a growing interest on how renal NIRS can add information to that population of kids.
Yep, absolutely. I think you're totally right. And I think my hope is in the future, in 5-10 years, everybody will be utilizing renal oxygenation as another vital sign. So we just need to know what the normal values are and then figure out how to respond to what abnormal values are. So similar to the cerebral work, which is probably 5 to 10 years ahead of maybe where we're at with the kidney oxygenation monitoring. Hopefully some big trials to come in the future with guidelines to try and optimize what kidney oxygenation is.
Matt, I had a great talk. I had a couple of questions. The first one is just kind of a practical one. You mentioned that you move the probe from side to side as you do the longitudinal monitoring. We've looked at in the past with the brain doing 2 channels at the same time, and the brain seems to be pretty much the same regardless of which side we look at. Is that true for the kidneys as well when you move from side to side?
Yeah, I'll have that answer for you in 2 years. So part of my current protocol is that for 2 different times in the first 10 days, we're doing 3 hours of bilateral monitoring, and really trying to answer that question of if right to left is different kind of in that early time frame. And I think that'll be really important as we roll out protocols for monitoring to know, like, let's say in the first week, the left is always 10 points lower than the right. That's going to be something that's really important to know.
And then my second question, and this, when you were going through sort of the background at the beginning and talking about the changes in the developmental trajectory of the kidney of a preterm baby, some of the cerebral work that's been done shows that early brain injury almost permanently alters the longitudinal trajectory for brain oxygenation. Do you think there's something similar for AKI babies early in the NICU course and how that changes over the long term?
Yeah, I definitely wonder that and want to answer that question. So also in my current study, I'm doing what I'm calling developmental checks. For each week the baby stays in the NICU, we do 3 hours of monitoring to try and get a sense of how that is changing throughout the NICU stay. Because I do think you're right that the babies who have acute kidney injury and knock off more nephrons may then have permanently altered kidney oxygenation. So definitely want to answer that question. And there has been some work in looking at babies with fetal growth restriction compared to babies who are normal, and even just the in utero fetal growth restriction affects kidney oxygenation. So I think we have a lot more to learn about that. Looks like
Jonathan,
Dr.
you wanna
Mincer.
ask a question? Yeah.
Yeah.
Oh, hi. It seems my microphone wasn't working there originally. So, it's interesting that when we look at cerebral monitoring, which has been and continues to be very heavily studied for the premature population, you might find abnormal numbers, but the number of interventions you can do in the first couple of days of life are quite limited, and usually more for counseling for the family rather than too many active medical decisions that you can make in the first few days of life. Renal, on the other hand, seems different, because if you know or suspect that there's an AKI, you have fluid and electrolyte decisions you can make, or avoidance of certain medications, et cetera, et cetera. What does it take to get there? How do you envision a future where renal NIRS monitoring provides guidance for or provides support for clinical decision-making in the future?
Yeah, I think you're exactly right. And I think we have a lot to learn just at baseline of how total fluid balance and fluid overload affects kidney injury in neonates. And there's a lot of work being done by the Neonatal Kidney Collaborative and other kidney researchers around the country to try and answer that question. But I think NIRS could be an important component of that. And one example would be in babies who have a PDA, and trying to figure out what your total fluid goal should be in babies with PDA. What is a hemodynamically significant PDA? Maybe in the future, hemodynamically significant PDA will actually be defined by what your kidney oxygenation is and not markers on the echocardiogram. So I definitely think that it could change a lot of our decisions. Or maybe if you have a hemodynamically significant PDA and you're trying to decide to treat with Tylenol versus ibuprofen or indomethacin, maybe the babies who have a normal kidney oxygenation, those babies are okay to treat with a nephrotoxic medication, whereas maybe the babies who have a low kidney oxygenation to start with might be better served with Tylenol that is not nephrotoxic. So I think, like you said, there's a lot of potential differences that we try and decide every day in the NICU of how to do different things. And we don't really know much about the kidney right now, so we just kind of guess, and maybe kidney oxygenation allows us to make a little bit more of an informed decision.
Thank you.
Yeah. I see another question here. I'm just going to read that out loud. So thank you for this great educational, inspiring presentation. So Lauren Gaddick's study utilizing the oxygen values from the UVC. Do you by any chance know where the catheter tip was located? So at our institution, we target the UVC tip slightly above the IVC junction. The sample would represent more of a mixed venous saturation in the RA from both the SVC and IVC. So curious how we did that. So we did grade where the UVC was. We eliminated any blood gases that were taken from a low line UVC that was below the diaphragm. And then we eliminated any where it was a higher UVC, where it looked like it was sitting in either the RA or the LA. So we tried to pick those ones that were like Goldilocks and just right, like IVC RA junction. But you're right, even those values may have been a mixture of both oxygen from the SVC and IVC. So my idea of using the UVC might not be totally perfect. And we did not have ultrasound to look at those catheter tips either. So those were X-ray, which we know are kind of notoriously bad at detecting where the UVC tip is. But I'm trying to look at that a little bit more in my current study to try and determine exactly where those UVC tips are.
All right. Well, if we don't have any more questions, just wanted to thank you again, Dr. Harer, for that wonderful presentation. And thanks to everyone in the audience for joining today.
Thank you, everyone. Really appreciate the opportunity.
Yeah. Hope everyone has a great day and hope to see you at our next webinar.